Ladies and gentlemen, again, it's my great honor and privilege to talk about hypothyroidism now from this particular angle, in the eye of reproductive endocrinologists. And endocrinology is an old but ever-growing field, as we know. It's one of the world's oldest fields of medicine, now with over 130 journals and REI, to which most of us belong, actually, is a distinct subspecialty in the field. Just have a quick look at Endocrine Reviews and see how prestigious this journal is. Now, let's be reminded that female infertility affects more than 50 million women worldwide. Women are more likely than men to have thyroid disease, so there must be somewhere of an interaction between female infertility on the one hand and thyroid disorders on the other. And the prevalence of hypothyroidism is 2 to 4% in women in the reproductive age, and subclinical hypothyroidism appears in up to 8% of women of reproductive age. Now, let's talk something quite interesting this evening. I've been listening with great interest and enthusiasm to Professor Khaldoun earlier this evening, who's talking about SCH, which stands for subchorionic hematoma. And here comes the very interesting science to talk about SCH in the very same evening, now this time about subclinical hypothyroidism. So SCH tonight has two different meanings with a lot of course, discussions there. Now, let's be reminded the thyroid in the upper part of the neck here could be in one way or another, be interrelated to the uterus and other reproductive organs. Now, from theory to practice, do we have enough evidence? I don't want to go through that discussion here again, but presence of evidence is not always evidence of presence, and absence of evidence is not always evidence of absence. And as Professor Richard Holton has said, that not all of the published studies are top quality, and half of our medical knowledge is not true. Problem knowing which half. And as Dr. Dalia has mentioned earlier this evening, we are moving from the medicine of yesterday, which is intuition medicine, symptom-based, to that of today, which is pattern-based or evidence-based, and to that of tomorrow, quite swiftly and smoothly and expeditiously, to precision medicine, individualized medicine, or algorithm-based. So the best thing is to tailor treatment and monitoring response to therapy in a very individual way, which is precision medicine. And I have put that sign of precision medicine next to the EFRE sign, just to say that we are about to see more of that sign in the coming, perhaps, months or years. So be familiar with that science. So here comes the most important question tonight. Could disorders of the thyroid gland prevent this wonderful couple from having this lovely baby? And the unfortunate answer is yes. But how? As is always discussed, as Professor Khaldoun has mentioned, you must always ask yourself why, be inquisitive, and ask for reasons. Now, we are all acquainted possibly with the genetic connections of the thyroid gland here residing in the middle, with all connections to the cervix, the uterine cervix, the fallopian tubes, the ovary, the placenta, to the testis in the male, and just no wonder from the Human Protein Atlas how the thyroid gland is genetically connected to all those reproductive organs. And the question is how? Through direct and indirect mechanisms. And to have a direct mechanism, the thyroid hormone receptors should be there in the reproductive tract somewhere to be responsive to the thyroid hormones. We know that the thyroid hormone receptors reside in the nucleus, and they act through transcription and translation modifications with the genome, and thyroid hormone receptors have been reported to be present in the ovary, in the uterus, in the fallopian tubes, in the vagina, in the levator ani, as well as many others. Just have a look at the site of thyroid hormone receptors in the growing follicle, in the granulosa cells, in the communal cells, in the decidual cells, and in the endometrium, endocervix, and endosalpinx. No wonder then that thyroid disorders could directly affect reproductive functions. What about the indirect mechanisms? Through controlling the pulse of the GnRH pulse, the FSH and LH dynamics, sex steroid metabolism, sex hormone binding globulin, and then the well-known relation of hyperprolactinemia to hypothyroidism, defects in hemostasis, and the frequently spoken of MTHFR gene mutations, and last but not least, modulation of uterine antioxidative status. Talking more focused on hypothyroidism, which has been reported to increase with advancing age. Most cases are due to chronic thyroiditis, autoimmune in nature, in almost 3 to 1,000 women per year, or to prior treatment of thyrotoxicosis in about half per 1,000 women per year. So progression from subclinical hypothyroidism to overt disease increases with the presence of thyroid antibodies or an already existently high TSH level. Screening should be carried out when symptoms exist. In hypothyroidism, we do expect in most cases to have a normal FSH and LH levels, but with otherwise a delayed or blunted LH response to GnRH stimulation. We have the association of hyperprolactinemia, galactorrhea, which interestingly disappears after thyroxine treatment, and considering impact of hypothyroidism to menstrual pattern, oligomenorrhea is the most common, followed by amenorrhea, polymenorrhea, or menorrhagia. And here comes the connection, which we are all acquainted, between the thyroid and the prolactin inhibiting hormone due to TRH and the TRF, and the well-known association of hyperprolactinemia with hypothyroidism. Moving on to the connection between subclinical hypothyroidism on the one hand and infertility on the other. Fertility is tested by an elevated TSH in the infertile women. Autoimmune thyroid disease, there is no significant difference between the two groups, and therefore screening is not recommended. Interestingly, treatment of subclinical hypothyroidism by thyroxine results in a 44% increased successful pregnancy rate, which is very encouraging. Moving on to SCH and fertilization failure. We all know that thyroxine is necessary, is of paramount importance for maximum fertilization rates and blastocyst development. Serum TSH is a significant predictor of fertilization failure in women doing or undergoing assisted conception. What is the relation of SCH and recurrent pregnancy loss? Women with increasing TSH levels had more frequent miscarriages irrespective of antithyroid antibodies. For women with recurrent pregnancy loss, we recommend screening. Actually, the American Association of Endocrinology, the American Thyroid Association, as well as the ASRM, they all recommend screening. Moving on to SCH and unexplained infertility. SCH may have an association. Now, let's stop here to say may and association. As Professor Khaldoun mentioned earlier this evening, not every association is a causation. And just stop at the word may, because it tells you that there is a great deal of uncertainty. So SCH may have an association with unexplained infertility in women, according to a team of researchers from Harvard. So say that it is an economical first step. Yeah, because it's cheap, cost effective, and results in satisfactory results. And SCH, bringing a TSH, this is the core target, is to bring the TSH value from a level higher than 4 to a level down to 2.5 at the maximum, which has no real downside. It could be a benefit once pregnancy occurs. In other words, it's better to be safe than sorry. I do agree with that concept, in fact. Now, moving on to overt hypothyroidism and infertility. Among infertile women, 4% have SCH, as I've mentioned, 4 to 8%, while 3% had overt disease. Common reproductive problems in women with overt disease include anovulation, luteal phase insufficiency, and menstrual irregularities in up to 70% of women. Now, how could overt hypothyroidism, in one way or another, be related to infertility? Altered peripheral estrogen metabolism, increased prolactin level, defects in hemostasis, disturbances in the GnRH secretion or pulse frequency. And interestingly, treatment with thyroxine results in normalization of prolactin level, LH responses with minimalization and amelioration of the menstrual disturbances, increasing the chances of pregnancy. And this is why it's an economical solution, because it's cheap, available, relatively free of side effects once used in the proper dosages, and produces wonderful results. Now, what about autoimmune thyroid disease and infertility? Most studies have reported an increased prevalence of AITD in infertile women, up to 81% compared to 10% controls. What is the relation of AITD, the autoimmune thyroid disease, and PCOS? Prevalence of autoimmune thyroid disease was reported to be threefold greater among PCOS patients. This is an aspect that has not always been studied despite the thousands and thousands of research works published in this particular field. And as you can see, we have an elevated thyroid peroxidase antibody and thyroglobulin antibodies in 27% PCOS women, in contrast to 8%. Whereas the relation of autoimmune thyroid disease to PCOS is quite strong, the association to endometriosis is rather controversial. Some say, yes, there is. Evidenced by the fact that of the increased prevalence of AITD in endometriosis patients, others say, no, there is no association whatsoever. And as I've said, the truth lies somewhere in the middle. It's not usually in the two extremities. Now, moving on to ART. In controlled ovarian stimulation, COS, we know that estradiol levels are very much increased, more than 2,000 picomoles per liter, which results in straining the axis, the hypothalamic-pituitary thyroid axis, impairing thyroid dynamics with an increase in serum TSH and TBG, thyroid binding globulin. In OHSS patients, we expect more severe thyroid functional changes than those seen in spontaneous pregnancy, just as VTE. In hypothyroid-treated women, a rapid increase in T4 is required to maintain euthyroidism. The timing of such increased demand is more rapid and pronounced in pregnancies after ART. So in pregnancies, basically speaking, we need more thyroxine. And in pregnancies achieved after ART, we even need a greater amount of thyroxine to support pregnancy. Now, here comes an important question: when to screen for thyroid dysfunction in women? Is it a universal screening or rather a selective screening? So universal screening is not recommended for women planning pregnancy or ART. Selective screening rather for women with endometriosis, ovulatory dysfunction, menstrual irregularities, hyperprolactinemia, and prior to stimulation. And let's stop here saying that it's not enough to carry out the thyroid function tests while performing the COS. It should be done before, because such tests actually are being altered by the stimulation itself. ART should be postponed until hypothyroidism is treated and normal menses are restored. I agree with that, and this is part of the counseling and the adequate preparation of patients before going for ICSI. We know how tough it is and how frustrating it is, and the results are not very much. In fact, they are less than 50%. And that's why optimization is all important. Thyroxine supplementation during ART has no beneficial effect. And this is one important aspect here. And another important question: when to treat thyroid dysfunction in women? T4 should be given to women planning pregnancy. Not all women. To which women then? Those positive for antibodies, particularly with history of recurrent pregnancy loss or past history of hypothyroidism, or whenever the TSH level is greater than 2.5. This is the recommendation of the American Association of Endocrinology in 2013. T4 should be increased to keep TSH level at all times less than 2.5 prior to stimulation, and for women with autoimmune thyroid disease who develop OHSS. But quite interestingly, adequate treatment results in a 30% increase in spontaneous pregnancy rates and almost the same increase in rates after ART, which is very, very much encouraging. Another important question, to screen or not to screen in pregnancy. Routine screening, some advocates say yes, others say no. And part of which is the ECOG, the American College in 2015 says no, do not routinely screen during pregnancy, but rather selectively. And selectively where symptoms and signs of the disorder exist, there is a goitrous, meaning an enlarged thyroid, family history of autoimmune thyroid disorder, history of high-dose neck radiation, prior thyroid therapy, postpartum thyroiditis, or a previously inflicted infant. How to screen? TSH is the first-line screening test to assess thyroid status in pregnancy. A very interesting piece of information which we should all stick to, so please go for doing a TSH basically. You might, as a screening test, we know that what a screening test really means, it's not a definitive test, it actually tests a large number of people, but it's not a finally diagnosed, just like diabetes. If you want to go for that for the diagnosis, TSH perhaps with free thyroxine are both necessary. But if you want to go for screening per se, TSH is all important. Universal screening for thyroid autoantibodies is not recommended in pregnancies unless there is prior recurrent pregnancy loss or other indications to carry out such universal screening. So it is, again, a selective screening strategy for thyroid autoantibodies in pregnancy. Now, shortly touching on pregnancy on hypothyroidism, pregnancy increases the dose in 1/4 of women, the dose increase in response to abnormal thyroid function tests, and the dose increase in early pregnancy is important. What is the effect of hypothyroidism on pregnancy? Very shortly, this depends on the degree of control. In uncontrolled hypothyroidism, we expect a list of complications, God forbid, preeclampsia, anemia, miscarriage, intrauterine fetal death, stillbirth, preterm labor, SGA, and I would like to, the new nomenclature is FGR, the fetal growth restriction, and developmental anomalies including a reduced IQ. Congenital hypothyroidism, the dreaded complication. This is why we actually much praise neonatal screening for congenital hypothyroidism carried out by the Ministry of Health, which has helped much reduce the impact of hypothyroidism on infants. Now, what about subclinical hypothyroidism? Does it have any impact, not only on fertility, the impact of getting pregnant, the impact on assisted conception, but what if a woman gets pregnant while having SCH? Is she at risk? Unfortunately, yes. Low IQs of the children has been reported, placental abruption, and last but not least, the preterm labor. What about treatment? Treatment of overt hypothyroid disease in pregnancy with adequate thyroid response should be carried out to minimize the risk of adverse outcomes. A very clear-cut statement from the ASRM not very far ago. T4 is safe in pregnancy and lactation. Very little crosses the placenta, and fetal risk is an absolute minimum. Patients who were already on thyroxine before getting pregnant should increase the dose by 30% once pregnant, even before doing a TSH analysis. How would we monitor treatment? TSH should be monitored every 4 weeks. Once euthyroid state has been achieved, TSH should be monitored every trimester until delivery. And those are the upper normal reference ranges recommended in the first trimester, no more than 2.5, in the second, no more than 3, and in the third, no more than 3.5 milli-international units per liter. Moving on to evidence-based medicine, and the best we have so far are the two, the ATA, the American Thyroid Association guidelines in 2017, and the ASRM, the American Society for Reproductive Medicine guidelines in 2015. We will shortly discuss the main points in those two guidelines. Excuse me. When possible, population-based trimester-specific reference ranges from serum TSH should be defined. And this is a strong recommendation. Very unfortunately, we don't have such reference ranges, and we should be busy doing that. And I actually am talking on behalf of EFRE. We should be busy doing with, of course, the endocrinologists across the country to reach to trimester-specific, population-based reference ranges, so it actually pinpoint our recommendations on that specific reference range. All pregnant women should ingest approximately 250 micrograms of iodine daily. And this is a fact we should encourage, a recommendation we should make clear to all women, not only mothers-to-be, but even before getting pregnant. Excessive doses of iodine exposure during pregnancy should be avoided, but this is rarely encountered in fact. Thyroxine treatment is recommended for infertile women with overt hypothyroidism who desire pregnancy. This is a very clear-cut recommendation, a strong recommendation. All women with overt disease should be treated before getting pregnant, especially if they are infertile and after getting pregnant, of course. It goes without saying, but it should be emphasized. Those with overt disease should be offered treatment, which is enough to bring down TSH to an acceptable level that below 2.5. Insufficient evidence to determine when it comes to subclinical hypothyroidism. The image is less clear, and as Professor Khaldoun mentioned, this comes in somewhere between the white and the black and white. So insufficient evidence to determine if thyroxine therapy improves fertility in women with SCH, thyroid autoantibody negative women who are attempting natural conception but not undergoing ART. If they are going for ART, then it's better to give, even if they have SCH. But what about women going for natural pregnancy, natural conception with an SCH? The picture is less clear. However, administration of thyroxine may be considered to prevent progression to more significant hypothyroidism once pregnant. So once she gets pregnant with a subclinical, she should be offered thyroxine. Furthermore, low dose of thyroxine therapy, somewhere between 25 and 50 micrograms a day, carries minimal risks. And that's why I've mentioned in an earlier slide, it's something better be safe than sorry. Women with SCH undergoing IVF or ICSI should be treated with levothyroxine. Now, this is important. So in overt disease and in women with SCH going for IVF ICSI, the goal of treatment is at all times to achieve a TSH concentration before getting pregnant, before the start of COS, a level not greater than 2.5 milli-international units per liter. This is a strong recommendation. Glucocorticoid therapy is not, I repeat, not recommended for thyroid autoantibody positive euthyroid women undergoing ART, another commonly abused drug. Just like low molecular weight heparins, many of us, let's say I'm one of them, but I'm not using it, but I'm not defending, I might use it sometimes. So glucocorticoid has no place in autoantibody positive euthyroid women undergoing for ART. When possible, thyroid function testing should be done either before or 1 to 2 weeks after COS. I've mentioned that earlier, because results obtained during the course of treatment, during the course of COS, as Professor Khaldoun has mentioned earlier, may be difficult to interpret, may be uninterpretable. Hypothyroid patients receiving thyroxine with a suspected or confirmed pregnancy, a positive home pregnancy test should independently increase the dose of thyroxine by almost 30%. So if she calls on the phone saying, oh, thank God I'm pregnant, even without performing a TSH level, we'll ask her to increase her dose by 30%. This, sounds difficult. But one way of doing that is to administer 2 additional tabs weekly of the patient's current daily dose. So let's, for example, suppose that she's receiving 50 micrograms of thyroxine each day before breakfast. Then she should be asked to add 2 more 50 microgram doses every week. So if she's receiving 350, she's moving on to, she has moved the dose to 450, which is about a 30% increase. Because we know the dosage of pills of thyroxine in the market is just 25, 50, and 100. This is a very strong recommendation with a high quality evidence. So we should always emphasize that once pregnant, kindly increase the dose even before performing a TSH level. In the setting of pregnancy, maternal hypothyroidism is defined as an increase in TS concentration, here again, beyond the upper limit of pregnancy-specific reference ranges. And since we, very unfortunately, do not have pregnancy-specific reference ranges, we have to stick to those of the American schools of 2.5. And if we stick to the German schools, we might be talking of a level less than that, even 1.5 to 2. So this is, again, a strong recommendation with a high quality evidence, and it only tells you how badly we need such pregnancy-specific reference ranges. In hypothyroid women treated with thyroxine who are planning pregnancy, going for pregnancy, okay, mothers-to-be, or even before marriage sometimes, serum TSH level should be evaluated pre-conception, and thyroxine dose adjusted to achieve a TSH value between the lower reference limit and 2.5. So this is very important. Just like folic acid, which we use 1 to 3 months before getting pregnant, at preconception, this is a strong recommendation with which I totally agree. Moving on to the ASRM guidelines, I'm not long, I'm just a couple slides away from the end. Currently available data support testing TSH in infertile women attempting pregnancy. If TSH concentrations are more than 4, patients should be treated with levothyroxine to maintain levels all the time below 2.5. If TSH levels prior to pregnancy are somewhere between 2.5 and 4, management options include either monitoring levels and treating when TSH rises above 4, or alternatively treating with levothyroxine to maintain TSH level at 2.5 milli internationals per liter, with which I am, of course, I agree with that latter policy. While thyroid antibody testing, as I've mentioned earlier, is not routinely recommended, but rather selectively, one might consider testing anti-thyroperoxidase TPO antibodies for repeated TSH values higher than 2.5, or when other risk factors for thyroid disease are present, and this is a grade C recommendation. If anti-TPO antibodies are detected, TSH levels should be checked, should be considered. If TSH level and is over 2.5, treatment is warranted. So, ladies and gentlemen, dear colleagues, attendees and EFRE lovers, REI specialists, everyone, this is my take-home message: thyroid disease in infertile women, always starting with the letter C. Let me remind you that it's a common problem, that it has clinically overt and subclinical forms, that it has complications pertinent to the mother-to-be before getting pregnant, while being prepared for natural pregnancy, for assisted conception, during pregnancy, and even postpartum. And moving on to neonatal complications, which might very unfortunately extend to infancy and childhood. But thank God, it's a curable disease. And the cure is very cheap, it's very cost effective. And if you started early in a timely manner, in a good dose, you end up with satisfactory and marvelous results. So it's all about the control. Control is more important before marriage, before getting pregnant, throughout pregnancy, and thereafter. And last but not least, this is why we are all here tonight, is that it is a multidisciplinary approach, not just the reproductive specialist, but also we're having Dr. Dalia, very much welcome. The endocrinologists are much welcome. So we are talking about a consortium of specialists and those interested in serving women to bring to life a very nice baby, as shown in the earlier slide. Thank you very much for your attendance, and I'll be ready to receive your questions.